ಅರುಣ್ ಅದಾನೋ ಇಲ್ಲೋ?
Yes. Thank you, Mr. Arun. My pranams to everyone. Good evening and a very warm welcome to this academic webinar organized by Karnataka College of Obstetrics and Gynec, that is the academic wing of KCOG, in association with KCOG and Belgaum OBG Society, CARE, and JN Medical College, Belgavi. As we gather today on the 30th of December, at the closing days of the year 2025, this season is not just another academic event, but also an opportunity to reflect on how gynecological practice has evolved over the years, becoming more evidence based practice, patient centered, and conservative wherever possible. We all know uterine fibroids, though benign, continue to impose a significant burden on women's health. So, fibroid care today has expanded to include effective, non surgical, and uterus preserving options guided by robust evidence and international guidelines. So, we have a senior consultant of obstetrics and gyne, a national leader in incision free in fibroid treatment, Dr. Mahantesh Karoshki, with us. We welcome you, sir.
Thank you.
I also welcome President of KCOG, Dr. Durgadas Asana, sir, and Secretary Dr. Shobha Gudi. In a while, she will be joining. And I also welcome Honorary Treasurer Dr. Shobha Bembalgi and all the KCOG Executive Committee members and all the KCOGians who have logged in today. My special welcome to our Dean of KCOG, Dr. Mrutyunjay Bellat, sir. Sir, I would just take a minute before we start this and before we look upon the opening remarks by our President of KCOG, Dr. Durgadas. Before that, it also gives us an immense pride and pleasure to congratulate our respected Dean of KCOG, Professor Dr. Mrutyunjay Baswanappa Bellan, on being conferred the honorary fellowship of Royal College of Obs and Gynes, the FRCOG, at the RCOG convocation held this month. Congratulations to you, sir, on behalf of KCOG members and KCOGA members.
Thank you so much. Thank you. Thank you. It's all belong to you people. Thank you. Credit goes to all of you.
May I now request President of KCOGA, Dr. Durgadas, sir, for your opening remarks.
Good evening, all, and welcome to this special scientific event. At the outset, first I thank my close friend Dr. Bellat for his FRCOG degree, what he got because of his immense academic work. Today I welcome our special guest Dr. Mahantesh Karoshi. On this, today is an auspicious day for us in India. It's called Vaikuntha Ekadashi, wherein the doors of the northern door of the Vaikuntha opens. In the similar note, we hope and our new thinking about the fibroid management will also be open today with the medical management of for the fibroids, which is very helpful, especially in two cases wherein in cases of infertility, the fibroid sitting very close to the cornua or the endometrium, or in cases of perimenopausal age, wherein you don't want to operate and just we want to reach to the menopausal age. with these few words, I don't want to take any more time. We want to hear from our very special guest who has joined. In spite of his busy schedule, he's traveling, he's flying. In spite of that, he made his time to join us and address us. With these few words, I welcome Dr. Mahanti sir for this webinar, and we are the whole KCOG and KCOG is eagerly waiting to hear you. Thank you.
Thank you. Thank you so much, sir. We have received wishes from our chief patron, Dr. M.G. Heramat, who would be joining us in a while. I also have received blessings from Dr. Nagaraj, our patron. I recognize the presence of our president-elect, Dr. Rajeshri Palladi, ma'am. Welcome you. Dr. Vanita Medgood, ma'am. Welcome you also. Now, with this note, we continue our webinar. So I request our Dean of KCOG, Dr. M.B. Bellat, sir, to take over.
Am I audible, Sonia?
Yes, sir. Yes, sir.
Yeah. Very good evening and good afternoon, Mantesh Karoshi. I think
you.
what a proud moment for any teacher in their life, where he will be able to learn from his own student, and where that is a proud student, that is Mantesh Karoshi. And it's a great opportunity for me to introduce and privilege to introduce my very own student, Dr. Mantesh Karoshi. And he was a very sincere student right from the beginning, and he himself established after completing his MD from our institution, and then he went on to do the MRCOG. He joined the UK, and I tell you, he had a brilliant academic career, and he has established himself as a very well-known gynecologist at London. And he gets not only the patients from UK, from outside of UK. He is an alumnus of our institution, and he is a senior consultant obstetrician and gynecologist with over 15 years of consultant level experience. You know how difficult it is for any outsider to get into that senior consultant post at Royal Free London NHS Foundation Trust UK. And he is a UK trained specialist. He worked for a brief time as a lecturer in our institution after immediately his MD, and he has been mentored by Dr. Professor Kodkani, Dr. B.R. Desai, Dr. Swami, and Dr. Nilgar. He's authored more than 20 plus peer reviewed scientific publications, and he's co-editor for four medical textbooks, including, you know, that comprehensive textbook of postpartum hemorrhage, that is B. Lynch textbook. He is one of the main three editors, and this was launched by Her Highness Princess Anne. He is a recipient of a Bernard Barron Traveling Fellowship, that is from the RCOG, for pioneering work in postpartum hemorrhage. He has traveled globally at most of the places, and he has trained the OBGYNs at different parts of the country and different countries, and with the international clinical exposure in Argentina. He had even conducted workshops in China and other places. National leader in incision-free fibroid treatment. So this made me, he took to his clinic and showed how he is doing, and he shared his video. And that made me to see that this should be addressed to our own people. They should not be deprived of this. And he is an incision-free, national leader in incision-free fibroid treatment, instrumental in introducing radio frequency ablation for symptomatic fibroids, and he's the treating patient not only from UK, internationally. He's experienced in advanced medical management of fibroid using relugolix and linzologolix, and featured in national television for innovative work on non-invasive fibroid care. You know, the UK is a very conservative population, especially women. They like to conserve the uterus even at 65, 60, 70. This is what he informed me. So this made his job very easy, and I'm really grateful that he agreed in spite of his, the holiday tour to Austria with his family. He agreed to be there on today. So, Dr. Karoshi, I think your talk will speak more than what I'm saying, and I'm really proud to have him today as a speaker. Thank you. With that, I request Dr. Mantesh to proceed with his presentation. Thank you.
Thank you very much, sir. Thank you for your kind introduction, and thank you for all the audience, and I will do my best. In this presentation, what I'm going to focus on is to present my own patient's story. I have asked them, and they have sent their videos, which you're going to hear, because that makes you feel more real, like how patients, they long for keep their uterus. When I was a trainee, it became very simple for me to understand the concept of obstetrics and gynecology. Only two things. One, how to conduct normal delivery and how to do cesarean deliveries. And on the gynecology side, how to do hysterectomy, either abdominal or vaginal. Having seen great professors as an undergraduate trainee, I felt I can do this. And that made me to get into obs and gynae, because in my life, I like simplicity. If I don't understand in a simple way, I'm not interested in that field. So that made me gain entry into obs and gynae. So in this talk, what I'm going to focus on is non-surgical, or also called as incision-free fibroid treatment. So the plan of my talk is present my patient stories, explain the science behind it, and show my departmental audit and further thoughts, and what are the new GnRH antagonists and their place in fibroid treatment, and I'll take questions from you. And this is Victor Bonney, 1913. And as you know, he's considered as father of fibroid treatment or fibroid surgery. And the reason he
Are
got...
your slides are moving or slide is not? Slide sharing is not there. Slide sharing.
One second.
Yes.
Yes, sir.
Okay, 1 second.
Start again. 8 p.m. ಎರಡನೇ ವೆಬಿನಾರ್.
See now?
Yes, sir.
Vanita, please.
Are the slides moving?
Yeah, now it is there. Yeah, plan
Yes,
slide
sir.
is there.
Okay, now?
Yeah, Victor
Yes,
Bonnet
sir.
is there.
Okay, good. Thank you for letting me know. So
Yes.
the reason...
One second. All the audience, please mute yourself, please. It will disturb. Thank you.
The reason I'm showing Victor Bonney is, if you look at evolution of medical field, most of the inventions happened because of patient's demand, or there is somewhere strong feeling that hope this would have happened so that would have life or organ would have preserved. And in Victor Bonney's case, at a very young age, his wife has to undergo hysterectomy for uncontrolled bleeding secondary to fibroids. And he was a gynecologist himself. So that made him to think, how can he preserve other women's uteruses because of fibroids? So that was the first landmark in terms of saving uteruses after removing fibroids. Now, in this picture, what I'm demonstrating is this little fibroid. Why am I showing this is, in my day-to-day practice, when I consent women for fibroid surgery, such as a myomectomy, either it's open or hysteroscopic, I warn them in advance that 30% of the time in 5 years down the line, you probably will need another surgery. The reason is I can only remove what my fingers feel, tactile sensation. But if I can't feel it, if it is too small, you will have to accept it. And that is very important, especially in the field where I work, in the place where I work. And I myself have seen a lot of women every now and then, having had third myomectomy, fourth myomectomy, wanting to preserve their uteruses because of these small fibroids growing over time. Right. Are you seeing my slide moving?
Yes, yes.
Okay. So in this slide, what I'm showing is the invasive scale of fibroids, starting with either your Zoladex, Prostap, or newly available Relugolix, Linzagolix, to Sonata, which I'm going to talk about, to hysteroscopic myomectomy, or combination of procedures, up to uterine artery embolization to myomectomy to hysterectomy. Now, this picture demonstrates type of fibroids classified by FIGO, where type 0 is opposite of type 7. So the more closer to the cavity the fibroid is, the more they present with heavy menstrual bleeding. More the fibroid is away from the cavity, they present with pressure symptoms like difficulty in micturition, frequency, or constipation, or difficulty in emptying. But if a patient has combination of fibroids, then she will present with combination of symptoms. Now I'll start with my patient's story, and she's a real patient, my patient number 1.
I'm Caroline, I'm 44, I'm from North London, I live in Enfield, and I work as a primary school teacher. I first realised I had fibroids after a series of appointments with my GP to talk about continual bleeding in between periods, almost all the time. I was initially sort of told, oh, you know, it will settle down, what contraception are you on? I was asked to go and get the Mirena coil, so I got the Mirena coil. It didn't have any positive impact. So finally, after that, I was sent for scans, and that highlighted several fibroids. The symptoms were, by this point, horrendous. So I was bleeding all day, every day. On an average month, I'd have maybe 1 or 2 days where I wasn't bleeding. So I had to take 2 or 3 changes of clothes into work with me all the time. I had to have my classroom positioned directly opposite a toilet, even though that wasn't the normal classroom for the year group I was teaching, simply so I could have access to that when I needed to go. There are so many aspects of life, normal life, that I took for granted that I just simply couldn't do anymore. So we're talking over a year since I'd first gone to my GP. I saw the gynecologist for the first time, and he said that due to the severity of my symptoms, he fully expected that I would need a hysterectomy. I'd say my mental health was really suffering at this point anyway, because of the impact on everyday life. So to then hear, we're going to take out your uterus and you probably can't, or you definitely wouldn't be able to have any more children, that was a shock. But before they could even think about doing that, he wanted to try ablation. And that's when I was put on the waiting list and finally met Mr. Kroshi. And he said, well, actually, I think you're going to be a perfect candidate for this new treatment that we've got. It's called Sonata. And at that moment, everything aligned. It sounded like an absolute godsend. And quite frankly, it has been. The day I had the Sonata treatment, my life changed in every single way for the better. And the recovery as well was really, really simple. So within about half an hour, a cup of tea and a little sandwich later, I was on my way home. I had some mild cramping over the next couple of days, and that was it. I was back at work by the end of the week. Life was instantly transformed. There are things that I just couldn't even dream of doing before that I can now do, from taking the dog for a walk without having to plan it, to meeting up with friends, to wearing lighter colours, to going on holiday, to going to the gym. I can do all this again, whereas before I couldn't even think about doing any of that. Sonata treatment has completely changed my life.
This testimonial.
And Caroline.
All right. So this is real. And luckily, she was my first patient. And as you heard, she gave this testimonial for the video TV interview. And this was her fibroid. And it measured about 6 centimeters. And she actually asked me to do it under local, even though I was hesitant to do it under local because she was my first patient. And I did it, and it worked very well. And the other thing is, as you can see, that she has weight issues. And one of the common problem in UK, at least we face, is 50% of population have obesity. And when I was speaking with Professor Bella, and he said India is not immune to obesity. So as you know, obesity makes surgery complex. So in other words, the incision-free fibroid treatment has a role when patients have comorbidities. This is my second patient now.
Hi, I would like to talk about my experience of seeing Dr. Karoshi for treatment of a quite large fibroid that caused me very heavy bleeding. Many doctors told me that it can't be treated with the Sonata method, that I need to have a hysterectomy, which is a very serious and invasive operation. Dr. Karoshi was incredibly caring, helpful, and circumspect in ordering several tests to be sure that the Sonata method could actually be helpful for my case. And as it turned out, he was hopeful that it would be. I had the operation about 3 weeks ago. I was quite nervous beforehand, and Dr. Karoshi reassured me, but he also put me in touch with a patient of his who had had the same treatment, which was really encouraging. So he's a very thoughtful and caring doctor. And when I had the operation, it turned out to be a very, very quick and incredibly effective cure for my problem. So I went in with heavy bleeding, barely controlled with very strong medication, and I came out, with a little bleeding, and already a week later, I have nothing. So this is really quite transformational. It certainly transformed my everyday life. The operation itself is not a big deal. A day later, I could already function, and 3 days later, I went back to work. And actually, it didn't have any lasting impact apart from really, really getting rid of my massive problem that had caused me so much pain and worry and was in the way of my everyday life. So I can highly, highly recommend Dr. Karoshi. He's a caring professional and really gifted surgeon also. Okay, good luck.
Okay, moving on. So this is the operation record. I've taken a screenshot of it, and the size of her fibroid was about 7 centimeters. And you can see the white rim here, means it was more of a type 1, type 2 FIGO fibroid. And what we use is called as overlapping technique. You will see it soon. I will show you some videos about it. So you create a circular thermal effect, and you overlap, and you overlap, and you overlap. So you can see here that I've used 8 ablation cycles, varying between 3 minutes to 2 minutes. In total, about 20 minutes of 8 ablation cycles. So the idea is to create circular thermal effect. And the advanced technology enables us to map the fibroid while doing the procedure. And then you create these heat effects in a 3-dimensional way. And you can see with your own eyes how this is happening. Sorry. So this is my patient who agreed for me to video her feedback whilst she's undergoing the Sonata procedure.
Yep.
So Elzbieta, you're having Sonata treatment at the moment, correct?
Yes, that's correct.
So if you give us a few words, like how you're feeling.
Very good. I
Yeah.
feel no pain whatsoever, just little cramps like before period during the first maybe day. And yeah, I feel pretty good.
Okay.
So
good.
far, yeah.
Okay, so we are halfway through the procedure.
Halfway through.
Yeah, another 1 minute left. So what you're seeing is the screen. You can see it on the red circle. It's slowly getting whiter if you look at it. Yeah.
So the size of the fibroid is 6 centimeters.
6 centimeters, correct. Yeah.
Yep.
All right. So we saw a few patient stories. We saw some live recording. What I'm going to do is demonstrate animation of Sonata treatment.
Innovative Sonata system combines real-time intrauterine ultrasound with radiofrequency energy to provide an incisionless, uterus-preserving treatment for women with symptomatic uterine fibroids. The Sonata treatment device is inserted through the vagina and cervix and into the uterus. The intrauterine ultrasound probe allows the physician to survey the uterus and locate fibroids. The physician uses the intrauterine ultrasound probe to target specific fibroids. Graphics are displayed on the ultrasound image to guide the operator. No manual measurements are required. The red ellipse represents the ablation zone, and the green ellipse represents the thermal safety border. The thermal safety border must stay within the serosa at all times during the procedure. The operator adjusts the size and depth of the ablation zone using the purple joystick on the handpiece. The introducer is advanced to the center of the fibroid, and the operator uses the purple joystick to align the smart guide to the introducer. The treatment device is rotated to confirm safety. The physician confirms that the thermal safety border is within the serosa using the gray button on the handpiece. Needle electrodes are deployed into the fibroid, and the treatment device is rotated again to confirm safety. Radiofrequency energy is delivered. Ablation times range from 1 to 7 minutes depending on the size of the fibroid. The needle electrodes and introducer are retracted to allow for additional ablations or removal of the treatment device. 50% of women return to normal activity by the next day. The ablated fibroids shrink over time, and most women experience a reduction in symptoms and heavy menstrual bleeding within 3 months. All right, so if you remember the First Lady Caroline, I actually had a chance to speak to her immediately after her procedure. So this is her feedback. Caroline, please tell us how you feel now. You had a Sonata ablation of fibroid treatment a few minutes ago.
Yeah.
And now you're in the recovery. And how do you feel? Please tell us.
I feel great. I feel fine. I'm wide awake, much better than having a general anaesthetic. I'm feeling groggy after. I don't feel any pain, just the mildest of cramping that you'd expect anyway. And yeah, it was a really positive experience.
Okay, thank you.
Okay.
Caroline. All right. So
Frequency ablation.
what I'm going to do is I've given you the taster, I've given you some patients, and I'm going to demonstrate what is the science behind radiofrequency ablation.
a technique we can use to treat isolated tumors in the body. And what do I mean by isolated? Isolated is one or two lesions without extensive metastatic disease. For instance, this patient who a few years ago had essentially a normal looking liver. The density of the liver is homogeneous and there's no nodules or abnormal mass lesions growing in the liver. A follow-up scan a few years later shows extensive metastatic disease. Everywhere you see one of these low density or gray lesions in the liver is now a metastatic foci. This is not a good appearance for radiofrequency ablation. There are too many lesions to treat with this particular technique. This patient, on the other hand, who had a scan back in 2008 showing the right kidney to be fairly normal, a follow-up scan in 2010 showing a small little cortical lesion, very nonspecific. And finally, in 2013, there's definite interval growth of this isolated mass lesion on the posterior cortex of the right kidney. This measures approximately 2.7 by 2.1 centimeter. No other lesions were found in the body. So this would be a great lesion for radiofrequency ablation. So what is radiofrequency ablation? In general terms, it's simply a way to cook the tumor right where it sits. We're trying to heat up those tissues, denature those proteins, and basically kill that tumor where it sits, preserving as much of the normal tissue around it. Graphically, if we look at the liver and we go inside and we would find an isolated tumor inside of the liver, and we would diagnose this with a CT scan, just like some of the scans that I showed you, and we would use CT to then guide a needle into the abnormality. The prototype needle for this technique is called the Levine needle. On one side is a plunger, and that plunger, when you push it forward, actually pushes out this array of needles that come out and curve around the tumor. It looks kind of barbaric, but it's a way to distribute this radiofrequency energy around the tumor itself. We would use CT guidance to basically guide that needle into the backside of that tumor. We would then deploy those tines, and we would watch those tines wrap around the tumor, again using CT guidance. And once it's appropriately positioned, we put grounding pads on the patient's thighs and their legs, and we hook the needle up to a radiofrequency generator. And basically what radiofrequency is an alternating current that goes between the needle and the grounding pads on the patient's thighs. And this alternating current, because it's a charged electromagnetic field, causes ions in the body, like the hydrogen and the oxygen in the water, or the sodium and the chlorine and the salt that's in our body, to vibrate back and forth. And as this vibrates, it generates heat. And that heat is what cooks the tumor, literally cooks the tumor, and denatures those proteins in an attempt to destroy that local tumor. And what we do is we use a protocol to slowly heat that tumor. You don't want this looking like seared ahi tuna, where it's really cooked on the outside, raw on the inside. You want this well done, like shoe leather through and through. So we slowly instill this radiofrequency energy using a given protocol until we fully cook the tissue. And we have some indication of when that is complete, because we're looking for the resistance in the tissue to go way up. And once that goes way up, it means you've boiled all the water out of the regional tissues and have probably killed that tumor. If it's big enough, we retract those tines, pull the needle back again, and deploy the tines again somewhere in the middle of the tumor to make sure we get a thorough treatment through and through. If you look at our patient with the renal mass, you can see here is the Levine needle sticking on the far side of the tumor. And after that area was treated, the needle was brought back and deployed again, and the more peripheral portion of the tumor was treated. At the end, you can actually see these little dark areas all around the treatment bed. These are little foci of air where the tissues have heated up and you've boiled off some gases that have now formed in those regional tissues. Actually, a good sign. Follow-up CT scans will show that this tumor will eventually shrink over time and get resorbed from the body. And if this is an isolated mass lesion, this can be a definitive treatment of the tumor itself.
All right. So just getting your understanding more, the Sonata system has a generator, has an ultrasound tablet, and then it comes with the handpiece. Handpiece has two components. One is inbuilt intrauterine ultrasound probe, and it hooks to the needles you saw. And here I'm going to demonstrate, which I have done the video myself, and you will understand more of this handpiece. Okay, hi, I'm going to explain about this Sonata device. So Sonata device is used to treat fibroids, which are type 2 to type 5. And the way it works is it has got two control buttons. One is to fix the fibroid. So when I press the gray button, you will see that the needle is coming. So this will fix the fibroid. And then once we do the safety checks, we engage the electrodes, and you can see that the electrodes are slowly emerging out. Depending on the size of the fibroid, we decide how much electrodes to come out. And once we do the safety check, these electrodes will heat up to 105 degrees centigrade. So as if like water boiling temperature. And by doing that, the fibroids become non-functional. And that's how Sonata works. Okay. Now, this is me doing the Sonata fibroid ablation. And this is intrauterine ultrasound probe. It is here. And my probe is inside the uterine cavity. And I've done it, I've moved it a little bit faster, but it's not edited. So you will see that now. And I'll stop and start in between so that you understand better. So if you remember, the machine had a tablet which is connected for the ultrasound images. So what I'm looking for, sorry, 1 second. So what I'm looking for is this white line, which is serosal border of the uterus. So that is my safety margin. So I'm looking for confirming, I'm moving the uterus back and forth to be sure that I understand the serosal border. I'm already seeing the fibroid here. I've zoomed it. Now I'm going to test it a bit more. And if you look at the angle of the probe, I've changed it to 45 degrees. And it comes with this overlay artificial intelligence, and my needle has fixed the fibroid. And soon the electrodes are going to, they have emerged now. And you can see if you focus inside the red circle, you will start seeing this whitish change happening. So if you remember the science I showed you, so all those molecules are breaking up. So the cellular water content is breaking up because of the heat effect. And if you look at here, it is showing continuously it's more than 105 degrees centigrade. And this is the time it is taking to heat treat the fibroid. And that is the overlapping technique, 2.6 by 1.9 centimeter. This lady's fibroid is about 6 centimeters. So it will take about 6-7 ablation cycles. So this is how the actual ablation is carried out. Now, to understand, to make it more simple, what I have shown you here is radio frequency is nothing new to us. Your day-to-day hair dryer uses 60 hertz, and the Sonata device uses 500 kilohertz, and television set uses in megahertz. So in other words, the electrical energy we use day-to-day is what we use in the Sonata device. So this is a patient whom I did the MRI before the Sonata, and this is after a few months showing shrinkage. And how the Sonata technology has evolved. So initially, I only did Sonata, means I only ablated the fibroid, and I didn't do anything more. But the problem I started encountering was patients started experiencing continued vaginal discharge, even though I told the patients that it's an acceptable side effect. but from a patient point of view, they wanted more. So how I have to evolve to meet the expectations. So if you look at the old technology, the transcervical resection of fibroid, what used to happen was you can see that there is a bleeding happening. And in this, what I started doing is immediately following Sonata, I started resecting only for the reason that to reduce their chances of excessive vaginal discharge. And the other thing you notice in this video is that when I'm going to resect it following Sonata, there's hardly any bleeding. And that is something I'm more frequently doing it in the last few months. So if you focus on your right side video, where I'm shaving the fibroid, it's like almost like cutting the paneer or cheese. So that is something which I'm using more and more often just to help patients experience less side effects. So what are the criteria we use at our own hospital? So patients have to be pre and perimenopausal because the device is not licensed for postmenopausal, even though I have had patients being referred for management of fibroids in the postmenopausal women. The situation we come across in UK is lots of women are going on to take hormone replacement therapy. And when these women take hormone replacement therapy, fibroids do grow. No surprise, because they are dependent on estrogen and progesterone. So even though I've not done it, but I can see the push coming from postmenopausal ladies not wanting to undergo hysterectomy. And why can't I do it? Maybe in few years, my hands and arms will be twisted by women. But so far, I haven't done it. So we choose Figo type 2 to 5. And obviously, we don't treat cervical fibroids. And we can go up to 8 centimeters without GnRH analogs. And nowadays, I use GnRH antagonists. You will hear that also very soon. And how many fibroids you can ablate in one go? Up to 10 fibroids. Even though in this model, I say no adenomyosis, but there is enough evidence to think about providing ablative treatment women with adenomyosis. And the big no is women having had either knee or hip joint replaced. I'm going to move. So this is another patient of mine. This fibroid is about 5 centimeter. It is type 2. And after 3 months, you can see that it is making its way out. And that is the internal loss of the cervix. You may be wondering, and we Indians are very much interested in what is the cost. So in order for you to get your understanding about the cost, the handpiece is single use, 2,500 pounds. So in Indian currency, about 2.5 lakhs. The machinery costs about 100K. So if you remember the generator and the intrauterine ultrasound, the tablet, that costs about 100K. The procedure costs, because we have to add theater time. Theater time is about 1,000 pounds per hour. So we do about one procedure 1 hour. So this is how I have to present to the governance board in order to get approval to do this procedure in my hospital. So roughly, for the NHS, where patients don't pay for their service or treatment, the taxpayer has to absorb 3,500 pounds per treatment. But where the taxpayer gets their money back is, if you remember, patient said she went back to work third day, and that is very important in the UK setup. because if I do open myomectomy, legally they can't drive for 6 weeks, and that is a economic cost taxpayer has to bear. So this is our own local audit. Now the numbers have gone to 70, but this is the last audit we did about 10 months ago. And what you see here is, this is patient statement saying, I want to avoid risks of major surgery, example, hysterectomy. So that is what they are interested. I mean, these are the operational results. We treated 30 patients, no major complications, and the NHS is almost always under stress for beds. So we talked about bed days released. So we released about 60 bed days for the other use. And pre-treatment symptoms, where majority of the patients experienced heavy periods. And that was the trigger for their visit to the doctor. And you can see, if you remember the blue line, it is getting smaller, means more manageable. It's not that patients want it to be completely dry. What patients want is manageable symptoms. And this is what my job is, to set the realistic expectations. So one of the standard question is, please set me the goal, and I'll see whether I can achieve that or not. And almost always patients say, doctor, make my periods lighter so that I can put up with my day-to-day activities. Okay. So what we demonstrated in the last 3 years is Sonata is a safe, effective, non-invasive treatment option for most of the fibroids. So this is my patient. After 3 months following Sonata, she gave her feedback. Rennie, you had a Sonata treatment about 3 months ago. And please tell me how your symptoms were before and how you're feeling now.
So before the treatment, I had very bad, painful periods, even that would last maybe for a month sometimes. It was really bad. I had to take time off work or just take, a random hour's rest because of the pains and the blood flow. And then after the Sonata treatment, so at the moment it's only been 3 months, I've noticed such a difference. My life's changed really. So my last period I had was like a normal period. The blood flow was just normal, wasn't heavy, didn't have any pains really, didn't have to take any, painkillers, etc. So for me, I've really changed my life. It's the best thing to do.
Thank you so much for your feedback. Right, so this is another patient who came to see me after 18 months of Sonata treatment. Anita, you came to see me in November 2022, and at that time you were having problems with your periods. Can you describe what you were having during that time, please?
That was one of the worst times of my life. The period was constant, almost every single day, very heavy with clots. And I could not actually function the way I wanted to. It affected my relationship, it affected my job. I had to go to hospital very often to check everything else. And then luckily we got to Barnet when I met you, and you came out with an idea to try the Sonata treatment, and that was the game changer.
Okay, so you had it in January 2023, Sonata procedure, yep. Correct?
Yeah.
And now we are into 16 months post-procedure. So now you tell me how it has changed your symptoms and your lifestyle.
It's 100% better. The period is almost back to normal. There is maybe slight, because it's already like halfway gone, which is very much so improved. But I can work. My partner is very happy. I can work to actually almost every day. There's the period is almost the same time as it should be. There is no clots. There is very minimum bleeding, like normal period used to be.
Fantastic. Would you recommend to your friends if they have a same problem?
Yes, definitely.
Thank you so much. Thank you.
Thank you.
All right. So, sorry, that was 16 months, not 18 months. Apologies. So moving on, I'm going to shortly touch base about my experience with GnRH antagonists. If you remember, I said I like to be simplistic. I like to make it very simple so that I can understand better. So on this side, on your left, I'm going to talk about Zoladex animated video. And then on your right is GnRH antagonist, Rieco or Linzagolix. Okay, so when patients receive GnRH analog, what happens is their pituitary releases surge of FSH and LH. So it's called a storm before calm. So that is your GnRH analog, the way it works. But GnRH antagonist is totally different. You give an tablet and it blocks the FSH and LH. So that's the animations that immediately, there's no storm effect. Sorry, there is no storm effect, correct. Immediately it starts working. And the other advantage is that it comes in the tablet form and the half-life is about 25 hours. Means if patient starts having side effects, you can ask her to stop. But in the Zoladex and Prostap side, even if she has side effects, your hands are tied for the next 1 month to 3 months. And sometimes the 3 months can be 6 months. So the relugolix and linzagolix, the new molecules and new frontiers in fibroid treatment, works by blocking LH and FSH production at the GnRH receptor level. And this is the normal medicine available in UK as called as Rieco, and it costs about £5 a day. So I tell my patients, as if you are having a cup of coffee, you will have to bear the cost. So the idea with relugolix available in UK as Rieco is it has got 3 components. One is relugolix, second one is estradiol, the third one is norethistrone acetate. And that combination makes the estrogen levels at a therapeutic range so that the fibroid shrinks, but she doesn't experience menopausal symptoms. It's 1 tablet a day. And you can see that almost 90% reduction in menstrual blood loss volume. So we are talking about menstrual blood loss, not the fibroid shrinkage. This kind of treatment is especially useful when women are transitioning from perimenopause to menopause. All right, so this is my patient, and you can see that April 2024, she said, I don't want a myomectomy or hysterectomy, and help me with. And I said to her, look, recently we have Rieco, and she was very keen on trialing it. And she took it April to June, about 14 to 15 months. And she was also keen to know what her fibroid is doing. And if you look at it, it's about 12.5 centimeter down to 11.2 centimeter. I mean, from a centimeter point of view, it's only 1.3 centimeter reduction. But when I asked the radiologist to do the volume calculation, volume reduction, I found out that it is 30% reduction in the volume. And actually her symptoms of urinary frequency, urgency have almost disappeared. And she was happy to carry on for the next 12 months. So it's a newly evolving field. And I've told my patient already that she will need bone density scan. But it also makes me think not all big fibroids do need surgery. We need to be more patient. We need to be more confident in managing fibroids. In other words, there are other ways to help women, not necessarily to consider the invasive options. I think this is the end of my talk. And I can see that in the chat message, 10 questions, but I'll ask Professor Bella or his colleagues to moderate it so that I can focus on questions rather than reading the chat messages.
Karoshi, it was a fantastic presentation, showing also the satisfaction of the women and how they felt, and after the treatment, how they felt. I think more interest is on medications, and I think it was an amazing presentation, and you showed those beautiful videos. There are questions. I think Sonia, who is going to moderate those questions. Before that, I have one question on
Sure.
the relagolics or the allagolics. What we have here, instead of the Roeco, we have here is Reluse in India available. Our experience is limited because it has recently come into Indian market. So I just want to know what, after stoppage of this medication, will it revert back?
You mean symptoms or you mean the size?
Symptoms and the size.
As you know, it's a newly available medicine even in the UK setup. I do tell patients that once you stop, very likely your fibroid will go back to how it was before and how your symptoms before. So the answer to your question is yes.
Yeah. That's Sonia, please go ahead.
Yes, sir. Sir, I would request Dr. Vidya, but if she's around. Madam, Dr. Vidya.
Hello, Sonia. Can we request the screen share to be stopped?
Yes. Miss.
Oh, sorry. Okay, I'll do it. Stop the screen share.
Thank you. Thank you.
Thank you, sir. Thank you, madam. Dr. Shubha Gudi is our president of, secretary of KCOG, sir. And initial start of the program, we missed madam, but then officially we welcomed you, ma'am.
No.
Any questions
it is
from
fine.
you, madam?
Any
questions from
I
you,
just
ma'am?
wanted to share a bit of experience with the Reluise that we are having currently in the market here, quite easily available. And I think, first of all, let me congratulate Dr. Bellet for getting such a fantastic speaker to KCOG and KCOG. And I'm sure Dr. Durgadas, our beloved president, joins me in complimenting you, Bellet, for bringing him in. Thank you, Dr. Mahantesh, for sharing your wonderful experience in this new modality of treatment. Now, much as we would like data on Indian women, right now we must look towards your experience and learn from it. We are very happy to do that. But then the cost factor is quite prohibitive. And since the GnRH antagonist has arrived in the market, we have started using it. And I must share that I have reasonably, okay experience with it so far, fingers crossed. Because just now we have started about 15 days or 1 month, we have started using the drug. So the question which Dr. Bellad asked is very pertinent. And I also feel that we have to counsel them about stopping the drug and the revert of symptoms. But I have a feeling, because we have seen this with other medications for fibroid. We have been using ulipristal as well for some years in the past. And actually speaking, maybe it is related to the age. The reversal of symptoms after stopping is not as aggressive as it was earlier. I may not know the reason right now, but women do benefit from medical management in the long run also, even if they are slightly remote from menopause. For example, if they are in, because one thing that we need to understand about Indian women is the menopausal age is a little earlier than the rest of the world. So the estrogen probably starts, dipping by around early 40s. And our women's reversal of symptoms right now are not as fearsome as we expect. So maybe Reluise will work better for us. I'm hoping for that. I'm hoping for that. But yes, you made it a very clear directive that it is more suitable for women closer to menopause as of now. So that was the input from my side, Sonia, because I wanted to share the
Yes, yes.
experience. Thank you so much for the time. Thank you.
And I also add on the pictorial presentation of the difference and the storm which is explained also, I think, ma'am, can just consider that also.
There is one question by Sudha Sonia on.
Yes, sir. There are a few
ready?
questions.
Yeah,
Yes,
please.
sir. So there's one question from Dr. Rashmi Patil. In your experience, was there any incidents where the tip of the electrodes were broken, sir?
Answer is no. I have attended several one-day courses about Sonata myself, and we have asked the same question to the producer of the device. They have never come across. So they put it this way: it's quite a sturdy machine. Their answer is no, so my answer is no. Obviously, things can go wrong, like cars can break, but so far, touch wood, I've done 70 cases, and we always count the needles at the end of the procedure. You can push them out and count. There are 7 in number, so you count.
You have a separate jack or something, sir, because you said you can count on the number of electrodes which you cannot, the number. So how do you recognize that, how many numbers it needed as per the size of the fibroid?
No.
Volume?
No, sorry. When you engage, maybe I'll go back. When you engage the needle, they all 7 comes out.
Okay. So my understanding is it's not under anesthesia. So if there is any movement in the patient's, if the patient is moving a little, is there any injuries otherwise?
No. So let me be clear. If a patient requests, she wants procedure under local anesthetic, I will do it for her. But I never say you have it under local, because the way it works is I do tell them that you can have it under local, but it is not mandatory. Okay. And the question about patient moving, you fix the fibroid under ultrasound guidance. And then once you're sure, it has to pass several series of tests before you engage the electrodes. If patient moves, the fibroid moves. It's not going to perforate.
Okay. So then you say the thermal injury chances are also very less.
Correct. Because if you remember, I showed you the traffic signal sign.
Yes.
Green and the red. Yes. So you stay in the red zone. Green, don't cross it.
Okay. So there's another question. Any degeneration and infection post-ablation or any myoma needed a vaginal excision?
I've done one. She needed twice resection because of the enormity of the size. But we do educate patients because the type 2 fibroids, once they become non-functional, the uterus starts contracting and starts pushing it out. It's all about educating the patients. Yeah.
Sir, do you have any follow-up protocols for this? You mentioned otherwise.
See, UK health system is funded by taxpayer. You can do many follow-ups in the private world, but you have to justify. And the usual education of the patients is if your symptoms are met with expectations, you don't need a follow-up. So answer to your question is, I outrightly tell them, you don't need a follow-up. But I do bring them at 6 months just to see how they are doing. And sometimes some patients, they really feel that they don't want to be outside the horizon and they would rather be followed up. But in actual fact, they don't need a follow-up.
So in your experience now, any case of infertility where you have done Sonata and they've conceived and delivered?
Sure. So I've done 2. It's not that I wanted to do, because patient already has had 2 open myomectomies and she was ready for the 3rd. And the surgeon said, I'm not going to operate on you because you carry a risk of stoma. So he was my good friend and he said, why can't you go to him and just ask whether you are suitable? So I did it for her. Not sure whether she has fallen pregnant, but she definitely froze her eggs.
Okay.
The second patient, she was, her embryos, no, sorry, the second patient, she was ready for egg collection, but then her fertility specialist told her, your fibroid is in the posterior wall, intramural, and they can't pass the needle. And she didn't want either open or keyhole myomectomy. And I said, look, even though there are many pregnancies reported following Sonata ablation, I can offer to you on the understanding that it's an unlicensed indication. As long as you sign, I'm happy to do. Guess what? She signed and I did it, and she fell pregnant. So, I mean, she had an IVF because she was lesbian. So yes, it can be offered.
Okay. Any inputs on whether she had a normal delivery or C-section? If it was a C-section, any input on how the endometrial cavity looked like, sir? Or at the time of ET or at the time of delivery?
Sure. So let me answer the first question. She's still pregnant, so she hasn't delivered yet.
Okay.
What's the second question?
So your 4th video next presentation will be on that, sir. The 4th patient.
Yeah. Yeah, she's happy to give a video interview. Okay. The evidence shows that actually Sonata ablation doesn't cause intrauterine adhesions. And actually you can move the traffic line circle out of the endometrium. So you don't cause thermal injury to the endometrium. You move inside the myometrium, the circle. So in other words, you don't cause Asherman syndrome by Sonata.
Yes. Okay, sir. The question, cost of the Sonata machine, I think is answered. But cost of Sonata machine in India, this was an approximate calculation. What was told.
I think Narendra Modi will charge UK 25-30% more. It's an American machine, so probably Trump will charge more for India. I don't know, 50%, is it? I think import charges are 50%. So 100K plus 150, so 1.5 crores.
Yes, we have our president-elect's question, Dr. Rajeshri Palladi. Madam, you would like to question, sir, by yourself? Dr.
Hi,
Rajeshri.
Sonia. Yeah.
Yes, ma'am. Your question, please, ma'am.
Yeah. Good evening, everyone. And it was a lovely presentation, Dr. Mantesh, to see the perspectives of saving the uterus and going for non-surgical management in the patient who refused to go under the knife. My question was, how do you do the case selections as to who will go for Sonata or who will go for the oral gonadotropin antagonist?
So let me answer the last question first. So the oral antagonist is for somebody who doesn't want even the needle put inside their body. Okay, so they are totally doesn't want to be sedated or anything put inside their uterus. And so far, my experience with GnRH antagonists are patients who don't want surgery and want to buy some time to get into menopause. And evidence shows that once they become actually menopausal, the shrinkage of fibroid is quite dramatic. And I was surprised in my own clinic. A year ago, I saw her uterus was 32 weeks. And I said, look, if you give me another year, come back and I'll see whether, by waiting, whether it will shrink. And it was like 18 weeks. I didn't give her anything. So what it taught me is that actually natural menopause can shrink faster. So we have to take a step back and say, if you take it, we monitor you, actually it shrinks faster than you think.
Okay, thank you. And would it be of any kind of advantage in a subcontinent like India, where maybe the cost would be prohibitive to go for investment of this Sonata?
No, actually, I'll answer in a different way. The Sonata is like, if you look at the cars, Sonata equated to Ferrari. But there are Fords and Fiats are entering into the market, like Koreans are entering. And right now, Koreans are banging on my clinic door saying, why can't you use our device? It will only cost, instead of 2.5 lakhs, it will cost you 1 lakh. So I'm exploring, maybe next year, this time, I probably will present the Korean device.
So it's just a matter of the preference of the patient who wouldn't like to go for the surgical management that they are subjected to, or given the trial with oral GnRH antagonist. Okay.
I mean, GnRH antagonist, it's in UK, I use it to like a bridge therapy. So for example, they have to wait 3 months. If I decide you can have Sonata and in my next theater list, my theater list is 3 months down the line. And how do I bridge that gap is to use GnRH antagonists. But I haven't had that many patients who exclusively went for Rieco. But some patients, they are either unfit for surgery, like BMI 42. And I tell them, look, you may end up with wound infection, and that may make you hospital bound for a few weeks. They don't like it. So they would rather take this new medicine or being operated. It's an evolving field.
Okay. So you do have a selection protocol for using the Sonata?
Sure. I presented it.
Yes. Thank you.
So do you feel priming with any analogs or analogs and then agonist and then taking them for the Sonata procedure would be beneficial?
Sure, because the Sonata device works effectively up to 8 centimeters. But some patients do have 9 centimeter fibroid. So, they feel disheartened that they have 1 centimeter more. Then I say, okay, if you take, GnRH antagonist, or Zoladex, and you can repeat your MRI and come back. I have done it on few patients, and actually it works better.
Okay.
Dr. Vanita has a question.
Dr. Vanita is a senior consultant. Madam, you would like to ask question? Okay. She's not audible, but then her question was, what is the age group you recommend and any contraindications? I think it's in respect to Sonata.
Sure. So my usual patients are in their 40s. They have completed the family. They have got single fibroid, usually varying between 4 centimeters to 8 centimeters. And their main problem is heavy periods. Sometimes some patients do have pressure symptoms, and I outrightly tell them Sonata is not to shrink the fibroid. It is mainly to make it non-functional. My standard analogy I use is you have a juicy fruit, like an apple or an orange. You'll have to learn to live with dried apple or a dried orange. As long as you follow that, I'm happy to do it for you.
Yeah, my concern was about infertility patients. I think you cleared that point.
Yeah, it's an evolving field.
Thank you. Thank you, madam. There's one more question, sir. I think it's the last question. Dr. Hemas asked, I think you've answered it. Do you need to use different size of electrode based on the size of the fibroid in the same patient? Does a single electrode be used for multiple fibroids in the same patient?
Sure. So the last question first. So the single device is one device, one patient. So if she has 10 fibroids, I'll be using the same device to ablate all the fibroids. The device comes with adjustable gauge. So if it is 2 centimeter, you adjust it to 2 centimeter. If it is 5 centimeter, you push it out to 5 centimeter. So it comes with an adjustable gauge. So you can decide based on your ultrasound how much to push out.
Thank you, sir.
There is one question by Dr. Sudha TR. Post ablation, any chance of infection or this in the chat box?
Sure.
Yes, sir.
So, okay. It's a known entity. We do give information leaflet to the patients. So just think of this. An apple has been heat treated. It swells up. It starts dripping the fluid. So same analogy I use. So this treated fibroid can act like a source of infection. So I give intraoperatively 1 dose of intravenous antibiotic, usually Augmentin, and go home with oral Augmentin. That is my practice. And I educate them. We call the condition as post-ablation syndrome. Usually they present with temperature because of this necrotic tissue releasing chemicals. So I tell them, don't be scared. Take regular non-steroidal anti-inflammatory drugs like Voltarol or ibuprofen for 2 to 3 days. We had 2 or 3 patients got admitted, but nothing major. We just gave them antibiotic and simple painkillers, and they went home.
Do you have any health-related scoring system to check the quality of life they have after this sonata?
I mean, that audit data I presented, I briefly presented, but it's quite enormous. Like it asks 50 questions. Answer is yes.
Okay.
I think any closing remarks? I think Dr. Mantesh, you answered most of the questions.
Yes,
yeah, anybody has any questions, you can pass it on to me. I can pass it on to him and get the answer and share it with the group. So, Dr. Mantesh, with all your busy schedule, you spent a lot of time with this webinar. I hope you will be traveling back to London with the flights on time.
Thank you.
Yeah, I think thank you for your time and the importantly the skill demonstration, which is very, very important. So on behalf of all of us, I thank you. But however, I request Sonia to proceed with her as per the schedule.
I request the Secretary of Belgaum OBG Society, Dr. Rajeshwari, you're here?
Yes.
So, please kindly deliver the vote of thanks.
Sonia,
Yes, ma'am.
Any
yes,
comments from the president, Dr. Durgadas?
No, I had given the first talk. It's a wonderful talk, sir.
Okay.
Even in the while you're traveling, you have addressed this. It's an eye opener. Like we had adenomyosis ablation last a month back. We had a workshop. We conducted the annual KCOG conference in Tumkur, in my place, and we had ablation of the adenomyosis using laparoscopy. And this is almost mimicking the same thing. That's what I was observing. It was a wonderful talk, sir. Yeah.
Thank you.
Yeah. Thank you so much, very much for finding time and joining us. Thank you, Bella, for getting Mahantesh
I think
Dr. Vanita.
Yeah, we must thank Dr. Bella for bringing such a wonderful speaker and a faculty. We are so lucky to have a first-hand information and all the patient's perspective and everything, including feedback and the procedure. We are really so lucky. Thank you so much.
Thank you.
Yeah, we hope to source you again as faculty. Hope to source you again as faculty in our future conferences. Yeah, for sure. Thank you so much.
Yeah, I don't know whether KCOG president and elect president, I have given him an open invitation to come to Gulbarga. I think Rajesh has to think about
Okay. Okay.
so I
Of course,
told
sir.
him,
Of course. Yeah.
he's a wonderful speaker, I think.
Yes.
And he actually showed his clinic in his London. I went there, and the way it actually how he's showing how the patients communicate, they are all really worth adopting, because future in India also the same things will
Yeah,
come, because
definitely.
communication is the problem solving thing in India also. So
Correct.
Mantesh, wonderful presentation. You get so many compliments. You see, thank you so much.
Good
Can I
evening.
speak only one sentence?
Yes.
Yes. Namaste, Sudha madam.
Dr. Karoshi,
Yeah, I know you.
as usual, you are very good man.
Thank you.
You are still doing work with Dr. B. Lynch?
No,
B. Lynch, has it continued?
No. B. Lynch is retired and he is.
He's retired. His health is not
No,
great.
he was working with him for some time. That's
Yes,
why.
yes. True.
How are
He has
you?
done a lot
All
of
good?
work on PPH, Sudha. He has gone
I know, sir. I
globally.
met him that time. I met him that time. He was calling my name in the whole hall. I do remember.
Correct.
Karoshi, all the
Thank you.
best.
Thank you very much.
I think you did come to India to Mysore when Dr.
No, Bangalore
B.
also,
Lynch
madam.
came.
Bangalore. Christopher B. Lynch
Yes,
was in
you
Bangalore.
came to Bangalore. You came to Bangalore and we were there. We did the conference and you did the workshop on PPH in Bangalore, and I remember you from there. That's the reason I was thinking, where we have met, and now suddenly because of Sudha, it is all coming back. Thank you.
Thank you.
No. Actually, Christopher B. Lynch himself came to Bangalore. I remember he showed
Yes.
red